Congestive heart failure, or CHF, refers to the inability of the heart to meet the metabolic demands of the body. Oftentimes, the heart tries really hard to get all that blood out there, but it can never quite catch up and the pump fails. Many of the cardiac conditions we'll cover in the cardiac unit will end here with heart failure. Knock out the heart's pumping ability with a heart attack, block off the heart's outflow tract with a stenotic valve. Over time, fluid starts to back up, pressure builds inside the heart, and you guessed it, congestive heart failure. And what better way to evoke the pain and heartbreak and fluid retention, I guess, of congestive heart failure than the timeless story of the Little Mermaid? What? No. This isn't the happy-go-lucky, oddly Rastafarian Disney version. I'm talking about the Hans Christian Andersen overtly depressing version. Yeah, no happy ending here. To make a long story short, the Little Mermaid saves the prince from a shipwreck, but the prince is betrothed or whatever to this other chick. So the Little Mermaid gives up her voice for some legs to be with him, but it's a little too late because the wedding ceremony has already started. Aw, look. He still misses her, though. Let this failing heart balloon remind you of heart failure. And here's the lesson for the kids. There's no such thing as true love, especially interspecies. So why can't the ventricles keep up? What, you gotta squeeze some stuff out every second? Really not that hard. Well, that brings us to one of the major classifications of heart failure. Either it's systolic or diastolic. Systole occurs when the heart pumps, so systolic failure means the ventricle can't eject enough of the fluids given. Failure to eject is represented here by the prince's best man as he creates a systolic spray of champagne by plugging the outflow with his thumb. Whenever we want to convey clinical events that occur during systole, whether it's a systolic murmur or systolic heart failure, look for that systolic spray. Systolic heart failure can be objectively measured by looking at the fraction of blood the ventricle ejects with each pump compared to the amount of blood it receives. This is called ejection fraction. During systolic heart failure, this fraction is usually reduced, hence the term heart failure with reduced ejection fraction. It's represented here by this falling fraction of wedding cake. Ejection fraction is calculated by dividing the stroke volume by the end diastolic volume. In other words, it's the blood you pump divided by the total blood you initially had inside the ventricle. While a normal ejection fraction value ranges from 55 to 80%, with systolic heart failure, you'll likely see values less than 40%. So take a close look and you'll notice that the cake server and plate kind of look like the number 40 to remind you of ejection fractions less than 40. The way we measure ejection fraction is with cardiac ultrasound, or echocardiography. Whenever ultrasound is important for diagnosis and monitoring of disease progression, we'll bring back our ultra-sketchy ultrasound bullhorn. Echocardiography can help not only with ejection fraction measurements, we can see chamber size, filling abnormalities, wall motion abnormalities, even pericardial and valvular disease. Physiologically, ejection fraction is reduced because of the reduced contractility of cardiac myocytes. The ventricle just doesn't want to pump. Let the weak little arms of our struggling waiter here remind you of that reduced myocardial contractility. He just can't deal with the load he's given. They're called bicep curls, brah. You're embarrassing yourself. When the heart can't eject, there's going to be a lot of blood left over in the chamber, so when your heart fills again for the next round, it kind of overfills. This means that the end diastolic pressure, or the pressure in the chamber when it's done filling, is going to be increased. Increased filling pressure is represented here by your next groomsman, trying a little too hard to force air into that heart balloon. Not only that, over time, when all this blood and pressure sits in your overfilled ventricle for too long, it stretches out and starts to look all distended and dilated. See? This means end diastolic filling volumes are increased as well. To recap, systolic heart failure means lots of diastolic filling pressure and volume. Compare that to diastolic failure. Instead of ejection problems, we've got filling problems. The ventricle is just too stiff and can't fill during diastole. This is represented here by one of the bridesmaids as she struggles to fill those champagne glasses, distracted, I'm sure, by the groom who is obviously undergoing some kind of major last-minute life reevaluation. I also want you to pay attention to that tiara, crowned with a diamond. Whenever we want to convey clinical events that occur during diastole, whether it's a diastolic murmur or diastolic heart failure, look for that diastolic diamond. During diastolic failure, the ventricle can eject blood just fine, and that's why it's associated with what's called heart failure with preserved ejection fraction. Remember that normal ejection fraction is somewhere over 55%, so our waiter here is lifting up that fraction of wedding cake without a problem. No contractility problems here. All right, so our ventricle ejects just fine. It just doesn't want to fill. That stiff, bulky ventricular wall just doesn't want to distend. In other words, we're dealing with reduced ventricular compliance. Let's face it, it's being a non-compliant jerk. So our bride here stomps on that marriage contract. All right, so diastolic heart failure involves a ventricle that just doesn't want to distend. So at the end of diastole, there isn't going to be any extra volume accumulating. Instead, what I want you to remember is that diastolic pressure building up. Just look at our next bridesmaid. Try as she might, she just can't cram any more air into that heart balloon. So end diastolic volume is low or near normal, but I can tell by her face that the diastolic pressure is building up. Next, let's go over the specific pathologies that cause heart failure. We'll focus first on systolic dysfunction. Why doesn't the heart want to pump? The most common cause of systolic heart failure in developed countries is ischemic heart disease. By far. See that black ischemic looking heart? This is usually due to coronary atherosclerosis, as represented by a recurring coronary crown. The inside is yellow and kind of gunky looking in order to evoke an image of an occlusive coronary plaque, depriving the myocardium of oxygen. Myocardial contractility decreases, leading to systolic failure. However, don't think of chronic ischemia. This heart-shaped loop with a broken string is a recurring symbol for acute coronary events, like heart attack. Just think of an acutely broken heart string. After acute myocardial damage and infarction, a big scar is left over. Scar tissue does not like to contract. Impaired systole means systolic heart failure, of course. Less commonly, systolic heart failure is caused by dilated cardiomyopathy, a disorder that incorporates a range of pathologies, all of which lead to structural changes to the myocardium. It gets thin, floppy, and just tired. This is represented by a recurring sketchy symbol, a big dilated heart bag, this time being held by the flower girl to hold her copious amount of petals. Check out our dilated cardiomyopathy video for a more in-depth look at the various genetic, inflammatory, and idiopathic conditions that like to make your heart all dilated and floppy-like. Valvular dysfunction, especially mitral or aortic regurg, can also play a role in systolic heart failure. With aortic insufficiency, for example, a bunch of blood dumps right back into the left ventricle after each systolic contraction. Valvular insufficiency, or regurg, is represented here by this jester dude who crashed the wedding, and now he's regurging all over his motley. Ugh. Get a hold of yourself, Jester. He's wearing that bicuspid jester hat to remind you of regurgitant pathologies like mitral regurg. Again, just think of all this blood regurging back into the heart after each contraction. The pressure increases, and before you know it, you've got a dilated, weak chamber and systolic heart failure. One more defect that can cause an increase in left ventricular end diastolic volume, putting strain on that floppy, fragile heart, is left to right shunting of blood. This occurs in something like a ventricular septal defect, kind of like the shirt defect on Fortunato over here. Think of it this way. Every time the left ventricle pumps, it sends blood into the right ventricle instead of the systemic circulation, and that blood ends up in the left ventricle all over again. You're retaining volume in your heart instead of pumping it out. Chambers dilate, get all floppy, and voila! Systolic heart failure. How about diastolic heart failure? Why doesn't the ventricle want to fill? What made the myocardial wall get all chunky and stiff like that? The most common cause of left-sided diastolic heart failure is long-standing hypertension. You see, when the left ventricle has to try and push against all that extra tension in the arterial system, it needs a little extra oomph if it wants to get the entire stroke volume out. So over time, the ventricle gets bigger and buffer. Although ejection fraction is maintained, the chamber is now smaller and less compliant. And that means filling issues, and eventually diastolic heart failure. Valvular pathologies can cause diastolic failure as well. See that princess hat? We'll bring back that red cone shape whenever we want to emphasize a stenotic aortic outflow tract. We've even included a little aortic arch there on the top. As she pulls down on that hat, think of aortic stenosis, when the left ventricle struggles to pump blood through that tiny stenotic aortic valve. So stenosed. So again, the myocardium reacts by getting bigger and buffer. It's the same with chronic hypertension. The heart is trying to overcome that extra pressure, but a thicker wall also means a less compliant wall, and diastolic dysfunction. Instead of a physiological response to increased outflow obstruction, diastolic heart failure may also arise if the myocardium is just inherently thicker. This can occur in the setting of hypertrophic cardiomyopathy, a genetic condition that leads to a big, bulky ventricular septum. We'll cover it in much more detail in a later sketch. For now, just imagine this unabashedly Celtic bridesmaid here, who's decided to ease the tension with a serene bag pipe ballad. That should get the party started. One of the pipes is tied off to remind you of outflow obstruction, and we've even incorporated a big old ventricular septum into the bag there. A big bulky septum means you're going to have filling problems. Also, instead of a big chunky myocardium, sometimes the ventricular wall is just too stiff to fill properly. We've mentioned dilated and obstructive, but what about restrictive cardiomyopathy? A range of pathologies that includes infiltrative disorders such as amyloidosis and sarcoidosis, or other fibrosing conditions such as radiation fibrosis, just to name a few. In all these pathologies, you've got junk and fibrotic tissue accumulating inside that ventricular wall, restricting wall movement. We'll always represent a restricted myocardium with a heart caught in a net, unable to expand properly. Check out our restrictive cardiomyopathy video for more info. I want to apologize in advance because we're bringing back ischemic heart disease. Yes, if the heart gets weak from chronic ischemia, the volume builds up and causes a floppy, dilated chamber. Psh, systolic heart failure. Easy. It's a little more complicated than that, however. It turns out that after ischemic events, the myocardium can get stiff and just doesn't want to relax anymore. A non-compliant wall? Yep. That means poor filling and diastolic dysfunction. So remember, with ischemic heart disease, you'll get a mixed systolic diastolic failure. The last cause of diastolic dysfunction involves the pericardium. Your myocardium is fine. Instead, it's the pericardium surrounding the heart that gets all stiff and restricts ventricular filling. This is called constrictive pericarditis. It's like this bow here, constricting the heart shape present underneath. A stiff, scarred pericardium can occur after multiple bouts of pericarditis, radiation therapy to the chest, cardiac surgery, or infections like tuberculosis. The heart gets trapped underneath and can't fill properly, leading to diastolic heart failure. All right, now that we've covered the main etiologies of heart failure, let's get into the histopathology. Whenever we discuss histopathology, we'll use a lot of pink hues. This will remind you of an H&E stain, one of the most commonly used histological techniques. Specifically, it will look like all that cytoplasm stained pink by the eosin counterstain. Let's look at systolic heart failure first, when the heart gets dilated and floppy. To see how the cardiac myocytes respond to all this pressure and volume building up, we first need to talk about preload. Remember, in systolic failure, the heart has trouble ejecting everything out. Too much fluid and pressure is left behind in the chamber. This increased volume causes an increase in preload. More specifically, preload is the end diastolic volume, the load in the chamber that the heart needs to move. At Sketchy, whenever we want to convey preload, we'll show a load getting pulled, or in this case, the groom getting pulled back to reality by his best man. Too much preload in the chamber over time leads to chamber dilation and a special kind of hypertrophy. You see, cardiac myocytes can't proliferate. So in response to all this stress, they get bigger. In other words, they undergo hypertrophy. In volume overload states, when systolic dysfunction leaves too much preload in the chamber, cardiac myocytes undergo what's called eccentric hypertrophy. See this eccentric eel here? He's got a kind of myocardial design in order to remind you of the stretched out myocardium. And if you look closely, you'll notice that the sarcomeres aren't stacking on top of each other to get thicker. Instead, they're adding in series to get longer. Isn't that crazy? Increased preload is actually activating gene transcription to change the structure of the myocytes instead of the myocardium. It's hypertrophy, yes, but along the length of the muscle. So the myocardium doesn't necessarily look thicker. In reality, wall thickness will be about normal. Eccentric hypertrophy instead lends to an overall increase in chamber size, kind of like this big, dilated underwater cave. Let's look at a few of the causes of diastolic heart failure again. Long-standing, poorly controlled hypertension, for example, is all about afterload. It's what the heart has to push against in order to move blood out of the chamber. If preload is all that weight in your trailer you need to move, afterload is the rough terrain that's inhibiting your progress. You need to step on the gas to power through the obstacles in your way. At Sketchy, we'll convey afterload with a load getting pushed by someone, moving it out of their way, like the maid of honor here pushing the bride over to her man. Arterial hypertension and stenotic valves are examples of increased afterload that the heart has to push through. To compensate for this pressure overload, the heart undergoes hypertrophy, but this time the myocytes are adding on top of each other in parallel. This is called concentric hypertrophy, and it causes an increase in myocardium thickness. Just think of the layers upon layers of shells spiraling inside this concentric conch. Macroscopically, look for an increase in wall thickness and decrease in chamber size. I mean, just look at that tiny constricted opening in between those hypertrophied walls. However, the other causes of diastolic failure that we've illustrated on the back of the boat work a bit differently. Take hypertrophic cardiomyopathy, for example. Instead of concentric hypertrophy leading to generalized increased wall thickness, the hypertrophy is isolated to the ventricular septum only, due to faulty genetics, which we'll explain later. Also, in restrictive cardiomyopathy and constrictive pericarditis, the heart isn't big and buff as much as it is stiff and non-distendable. Therefore, you'll likely see a normal chamber size and wall thickness, which we try to depict with this cardiac bow. Looks like normal wall thickness and chamber size to me. Serological workup of CHF includes two cardiac neurohormones called atrial natriuretic peptide, or AMP, which is released from atrial cardiomyocytes, and brain natriuretic peptide, or BMP, which is released from ventricular myocytes. So why isn't it VMP? Well, it was first discovered in pig brains, so yeah. But it gives us the opportunity for the perfect symbol, our sketchy BMP blimp. See how it depicts two outrageously dilated ventricles? Both AMP and BMP are released in response to stretching of cardiac myocytes in their respective chambers. BMP from the ventricles, ANP from the atria. These proteins have two major functions in the body. First, they decrease afterload by promoting vasodilation, hence the red dilated sleeves. This decreases systemic vascular resistance. Second, they help decrease preload and overall volume by promoting natriuresis, or salt excretion, which in turn promotes volume excretion, or diuresis. Just think of these salty sodium peanuts getting thrown overboard. Now that's salt excretion, also called natriuresis. And that spilled drink? If that's not diuresis all over his crotch, I don't know what is. So remember, BMP and AMP are released in response to stretched heart chambers, and they try to counteract this fluid overload by promoting salt and fluid loss. One way they promote natriuresis is by limiting the production of aldosterone, both directly at the level of the adrenal glands and indirectly through decreased renin production. Decreased renin, you say? Well, that means we have to include our recurring renin rain umbrella, falling overboard to remind you of BMP's ability to decrease renin levels. This promotes salt excretion at the distal convoluted tubule. BMP also helps increase the amount of solutes filtered by increasing GFR. This is through efferent arterial constriction at the glomerulus. Kind of like how our groomsman here pinches on the efferent end of his wacky glomerular straw before taking a sip. This helps with salt processing at the nephron, promoting natriuresis and diuresis. To finish up this sketch, let's go over a few physiologic changes that occur in response to this whole heart failure thing, which, let's face it, has been a total party pooper so far. Pooping all over your cardiac output. Well, your body has a few tricks up its sleeve to compensate for this cardiac output metabolic demand mismatch. These compensatory mechanisms will be illustrated on the lower deck, where we can see a waiter counting his tips for the day, his compensation, if you will. Sadly, each of these compensatory mechanisms has only transient benefit and are ultimately deleterious. Remember, whether we've got systolic or diastolic failure, what the body senses is reduced cardiac output, like on the steam engine here. Not looking good there. Let's see what to do. Oh, I know. Let's try increasing sympathetic nervous system activity. The release of norepinephrine increases heart rate, myocardial contractility, which increases cardiac output and blood pressure to get blood flowing to your extremities. Sounds good, right? And you know, nothing gets the blood pumping like a fight or flight encounter with a 10 to 15 foot long male freshwater alligator. You know what I mean? Notice, too, that his sleeve is all chomped and getting all vasoconstriction-y. That's because sympathetic activation also leads to arterial vasoconstriction in an effort to increase SVR and maintain blood pressure. Over time, though, it's a little too much pressure, but I'll get into that in a little bit. Low cardiac output is also sensed by the kidney, and that means activating the renin-angiotensin-aldosterone system. As always, renin is embodied by our recurring renin rain umbrella. Take a look at those two tense red suspenders as well. That's angiotensin 2, which acts on angiotensin receptors on vascular smooth muscle. In other words, we've got even more vasoconstriction going on here. I mean, I like the enthusiasm and all, but all of this increased tension caused by sympathetic activation and renin-angiotensin activity puts even more strain on that failing heart. As he pushes on that door, imagine all that extra afterload we've added to the arterial system that the heart has to push through now. That's not going to last long. Okay, low cardiac output. What else can we do? I got it. Okay, hear me out. What if we bump up the renin? Yep, that's that rain umbrella again. And then we can get some increased aldosterone release from the adrenals. As always, the mineralocorticoid aldosterone is represented by the accumulation of salty mineral crystals, also the perfect reminder of the increased salt and water retention that ensues. On top of that, when the cardiac output is low, it's time to turn up the ADH release from the posterior pituitary. And that means free water conservation at the collecting duct. Look, I get it. Aldosterone helps us retain volume. ADH helps with free water conservation and therefore even more volume. And sure, this will help get volume back to the heart and boost blood pressure. But here's the thing. The systolic and diastolic dysfunction that characterizes heart failure eventually leads to fluid backing up, either into the pulmonary system to cause pulmonary edema or into the venous system, causing peripheral edema. Just take a look at that sulked pulmonary life vest and edematous peripheral pants. So imagine that your lungs are filled and your legs are filled, but with a low cardiac output, your body conserves even more water and your edema just gets worse. You just can't win. As a last-ditch effort, in response to all this stress, the myocardium is able to undergo structural changes, also called cardiac remodeling. Remember that eccentric eel hypertrophy from ventricular volume overload? And that concentric hypertrophy from too much afterload pressure? That's cardiac remodeling. And as we've already discussed, this remodeling process occurs in response to the hemodynamic changes that occur during heart failure. In other words, all that volume and pressure overload. The big thing to remember here, however, is that neurohormonal activity is also directly responsible for cardiac remodeling. That's right, angiotensin 2, norepinephrine, aldosterone, they all exert direct effects on the myocardium. At first, these structural changes are beneficial. They help the myocardium deal with all the stress. Over time, however, the myocardium is prone to ischemia and arrhythmia. Not good. Look out for the remodeling sign on our sketchy farm course. It'll pop up now and again to highlight the drugs that can combat and even reverse cardiac remodeling. So, there you have it. Heart failure. The heart just can't win. And like our prince over here, it just can't deal with the pressure. You know? To sum up, let's divide the drawing between systolic and diastolic heart failure. Next to that systolic spray are all the causes of systolic heart failure, or heart failure with reduced ejection fraction. Coronary atherosclerosis and that coronary crown, volume overload from gesture regurg and left to right shunting, and that dilated cardiomyopathy sac. The rest work a bit differently, but also make the ventricle non-distendable. Coronary atherosclerosis, hypertrophic cardiomyopathy, restrictive cardiomyopathy, and constrictive pericarditis. The ensuing volume and pressure overload leads to compensatory mechanisms: renin, angiotensin, aldosterone, norepinephrine, which cause cardiac remodeling, which further decreases cardiac output, which leads to even more neurohormonal activation. You get the idea. All right. Now that we understand the basic mechanisms of heart failure, in our next sketch, we're going to dive into the clinical manifestations of heart failure. That's right. This love story has only just begun, my friends. And if I know Hans, there's some kind of necessarily violent lesson to be learned from all of this. So stay tuned, kids.